A very good morning, everyone. I'm Dr. Ruma Das. I'll speak on ROCK kinase inhibitors in glaucoma. So, ROCK kinase, Rho-associated kinases, that is ROCks, are small GTP binding proteins. They aid in regulation of cell structure, motility, division, and apoptosis. Research on ROCK kinase began in late 1990s. So, this is the metabolic pathway of ROCK kinase. So, indications of ROCK kinase inhibitors in ophthalmology. In Fuchs endothelial corneal dystrophy, use of ROCK inhibitors, eye drops, have been successful in preserving corneal clarity and visual acuity. In conjunction with other topical glaucoma therapies, ROCK kinase inhibitors have been shown to be effective in diseases of increased intraocular pressure like ocular hypertension and primary open-angle glaucoma. The ROCK pathway has also been implicated in retinal disease such as diabetic retinopathy. It is known that Rho and ROCK are expressed in retinal ganglion cells, which may promote vasoconstriction through endothelin 1. Therefore, use of ROCK kinase inhibitors promote vasodilatation and improve retinal blood flow, especially to the optic nerve head. So, this is a pathway and role in glaucoma. So, ROCK kinase inhibitors in glaucoma. The mechanism of ROCK inhibitors' ability to decrease IOP is through the direct action of relaxation in the trabecular meshwork and Schnapp's canal cells, causing increased permeability, which reduces the resistance of aqueous humor outflow. Some ROCK inhibitors decrease aqueous humor production through inhibition of norepinephrine transporters via vasodilatory effects on uveoscleral drainage and episcleral veins. Besides the effect of ROCK inhibitors on trabecular meshwork, other potential mechanisms beneficial for treating glaucoma are reduced postoperative scarring after glaucoma filtration surgery, improved blood flow to the optic nerve, presumably through the relaxation of vascular endothelial smooth muscle cells, neuroprotection and regeneration of retinal ganglion cells, and increase in corneal endothelial cell density and restoration of the damaged endothelial cells. So, ROCK kinase inhibitors role in glaucoma. In trabecular meshwork and Schnapp's canal, it increases the cell relaxation and permeability, decreases actin cross-linking, etc., and thereby causing increased aqueous humor outflow and thereby decreases intraocular pressure. Now, optic nerve increase in axonal extension blood flow, then retinal ganglion cell survival, leading to increased neuroprotection. In tenon fibroblasts, it reduces the fibrosis, glaucoma fibrosis surgery, fibrosis is reduced, and corneal endothelial cells, it increases cell proliferation, cell adhesion, decreases apoptosis, and thereby increases endothelial cell density. So, decrease of aqueous humor outflow resistance. In open-angle glaucoma, it is proposed that this elevation in intraocular pressure is due to the clogging of aqueous humor drainage canal through the trabecular meshwork. It is proposed that the best therapeutic remedy for open-angle glaucoma is lowering the IOP by enhancing the outflow of the aqueous humor. In primary open-angle glaucoma, it is widely thought that the initial site of neuronal injury is the retinal ganglion cell actions. So, ROCK pathway inhibition has shown to enhance the axonal regeneration. So, increase ocular blood flow. Large population-based studies suggest that lower ocular blood flow and perfusion pressure are risk factors for the incident development of glaucoma and progression of the disease. Strategies to improve retinal and optic blood flow may therefore be beneficial in the treatment of glaucoma. Mounting evidence suggests that the ROCK kinase signaling cascades a therapeutic target. ROCK kinase inhibitors can increase the blood flow by causing vascular smooth muscle relaxation leading to vasodilatation. ROCK inhibitors potential to reduce scarring after glaucoma surgery. Most common cause of glaucoma surgical failure is formation of excessive subconjunctival fibrosis. Trans-differentiation of fibroblasts into myofibroblasts is a crucial step in wound healing and scar formation. ROCK inhibitors serve as potent anti-scarring agents via inhibition of trans-differentiation of tannon fibroblasts into myofibroblasts. ROCK inhibitors preserve corneal endothelium. So ROCK inhibitors could play a role in increasing cell adhesion and proliferation in the corneal endothelium, allowing the preservation of corneal endothelial cells and slowing of apoptosis, may help with acute corneal endothelial damage that can potentially occur in cataract surgery. Studies shows the positive effects of ROCK kinase inhibitors on the corneal endothelium. So ROCK kinase inhibitors, there are two commonly used ROCK kinase inhibitors are ripasudil and natarsudil. Ripasudil has been clinically approved to treat glaucoma, also known as K115. It lowers IOP within 2 hours of instillation, given as twice daily dose, and side effects of concerned are conjunctival hyperemia, conjunctival hemorrhages, blepharitis, allergic blepharitis, etc. Natarsudil is both an ROCK kinase inhibitor and a norepinephrine transport inhibitor. As a non-epinephrine transport inhibitor, it decreases the reuptake of norepinephrine, increasing its effects on the body and alpha-adrenergic receptors. It has also been clinically approved to treat glaucoma, and its intraocular pressure lowering effect has been shown to increase with latanoprost. It is given as once daily dose in the evening. Its side effects are conjunctival hyperemia, corneal verticillata, installations, site pain, and conjunctival hemorrhages. So these are some studies. I'm not going into detail. So in conclusion, numerous treatments involving ROCK kinase inhibitors in ophthalmology have been researched. It is seen that eyes respond well with use of ROCK kinase inhibitors in lowering IOP, though they have ocular side effects, but those can be managed. Glaucoma treatment, ocular hypertension, corneal endothelial healing, and progressive forms of diabetic retinopathy have all shown benefits from its use. ROCK kinase inhibitors are being used in our hospital in lowering IOP, in primary open-angle glaucoma, and ocular hypertension, etc. Thank you.
Thank you, Dr. Ruma. I think you have given us a nice overview of ROCK kinase inhibitors. Any questions from the audience? I think ROCK kinase inhibitors are a very good addition to the drug therapy that we already had. But I think all drug therapies, they have their limitations, so it's best to have more than one alternative to do this. I think, and ROCK kinase inhibitors, they seem to fit the bill very well. They have multiple benefits. I think you have just heard that. The only issue with ROCK kinase inhibitor is that they, again, like other drugs, they have ocular side effects, and they actually give you a lot of red eyes. Both natarsudil and ripasudil, they give you red eyes, and many people actually discontinue for that reason. So I think from side effects point of view, they have a little disadvantage, but definitely there's another drug that we can rely upon now to lower intraocular pressure. So it's a good addition to our therapy.
Sir,
Yes, please.
so can we use as a first-line treatment?
One can use it, but if you look at the IOP lowering efficacy and the side effect profile, the prostaglandins, they still do better. Overall, they still do better. But in case you cannot use a prostaglandin, you have an option of using ROCK kinase. Well, I think not as a first line, but definitely you have a comparative data between different drugs, timolol mostly, timolol and ROCK kinase inhibitors, but also you have some data on the prostaglandins and the ROCK kinase inhibitors. So IOP reduction is more or less similar. Yeah, okay. All right, so I think we'll move on to the next topic. Thank you very much.
Dr. Sanjeev, please present your topic. The topic of Dr. Sanjeev's presentation is glaucoma demystified, but I think he will be speaking mostly on the diagnostic skill which we tend to miss.
Very good morning. Very good morning to all of you. As we all know that Gonioscopy is the examination of the angle of anterior chamber, and this is mandatory for the diagnosis and management of glaucoma. A brief idea about the history of gonioscopy. It is Alexiotrentus, the Greek ophthalmologist, who coined the term gonioscopy. And it is the Selgman who was the first to view the angle through the contact lens. He was the first to describe the blood in the Selms canal. Why there is need of gonioscopy? Angle of anterior chamber cannot be visualized because there is total internal reflection at the precorneal tear film. And light rays from the angle exceeds the critical angle, so rays reflected back into the anterior chamber and thus preventing the direct visualization of the angle. In this picture, we can see that as the angle of incidence is increasing, there is total internal reflection. 3 primary methods are direct gonioscopy, indirect gonioscopy, and indentation gonioscopy. In the direct gonioscopy, as the index of refraction of the contact lens, that was that of the cornea, there is minimal refraction at the precorneal tear film, and so light rays enters the eye. There are various types of direct gonio lenses. It's all about technique. So advantages are it can be used in sedated patients, and both the eyes can be examined at the same time, and surgical procedure like goniotomy can be performed. Now coming to the indirect gonioscopy, in this we use a mirror to reflect rays from the angle so that they exit the gonio lens at the much less than the critical angle, and they provide a mirror image of the opposite angle. There are the different types of. So this is important. Before doing this, room lights should be dimmed, size and intensity of the slit beams should be reduced, and they do not impinge upon the pupil because they will constrict and falsely open up the angles. What we see is a mirror image. The part of the angle that is viewed is 180 degrees away from the mirror that is being used. And it allows differentiation between the appositional and sanical closure because our whole treatment plan depends upon this. So if it is appositional closure, we will do the laser iotomy. If it is sanical closure, we have to do the filtration surgery. And it can create a corneal beige. So sometimes this is very helpful in identifying the Solvi line. What are the information goals we needed? Is the angle open or closed in normal position? It is a positional sanical closure, any abnormalities in the angle, and look for occludable angles. And after that, increase the room and the slit lamp illumination, and it will open up the angles. So now coming to the indentation gonioscopy. Here the lens is moved posteriorly, indenting the cornea and forcing the aqueous to the angle, and pushing the lens iris diaphragm posteriorly. And so this differentiates sanical closure from appositional closure. In this picture, we can see that in the appositional closure, there is opening of the angles, whereas in sanical closure, there is no opening of the angles. So over the hill or dive bomber's view. This is a special maneuver in case of steep iris. So ask the patient to look in the direction of mirror or move the mirror towards the angle being viewed. So these are the indications for gonioscopy. And actually, if it is the Van-Herix grading is grade 2 or less, in that condition, you have to do the gonioscopy. There are other conditions also, but it is important. Always do the slit lamp examination, do the Van-Herix grading, and see that if the angle is narrow. So then do the gonioscopy. There are the different indications. Now coming to the normal angle structures. From anterior to posterior is solid line, everybody is knowing. Meshwork, non-pigmented and pigmented part. Then oscular spur, ciliary body, and root of the iris. Solid line, this is the most anterior structure and demarcates the peripheral termination of the descending membrane. And two light reflections seen, one from the anterior surface of cornea and one from the posterior surface of cornea, and where they meet, they create a corneal beige. So this is very useful in sometimes faint Schwalbe line. Trabecular meshwork, anterior non-pigmented part and the posterior pigmented part. Sometimes there may be variations, like in the left side picture we can see that there is discrete line of pigmentation along the Schwalbe line, and in the right side of the picture there is wavy line of pigmentation anterior to the Schwalbe line. So that is called the Sampoleschi line. These are how to grade the pigmentation. Now coming to the Selms canal, it lies within the posterior pigment trabecular meshwork. In most individuals, cell muscle is not visual. It is visual when filled with blood. And sometimes we press the Goldman lens too firmly against the cornea, compressing the episcleral veins. Blood in the Salem canal is visual. This is the most consistent finding usually, and this is the most anteposition of the sclera, and light gray in color. But there may be variations also. In the right side of the picture, we can see that there is yellowish discoloration of the muscular spur. Ciliary body band is usually light gray to dark brown band, and it's a bit depends upon the portion of iris insertion, narrowing hypermetropes, and anterior insertion of the iris, and wide in myopes. In the right side picture, we can see that wide ciliary body band. Iris processes these are epithelial extensions from the iris on the trabecular meshwork, and it has to be differentiated from the peripheral antisynechiae. So it inserts close to the muscular spur and often found in normal angles. This is important. In the left side picture, there is iris process and peripheral antisynechiae. So peripheral antisynechiae is broad, whereas this is fine. And peripheral antisynechiae do not move with indentation, and it is not. So this is intact initiation also, rest movement, it obscures the view, and they extend beyond the muscular spur. So now coming to the normal blood vessels and neovascularization. Normal blood vessels, they have radial orientation, where the neovascularization, they do not have radial orientation. They are fine, they can branch, but normal blood vessels are thicker. These are the differentiating points between the normal and pathological blood vessels. The most important classification is ISGO classification, like PSCS, PSC, and PSCG. And these are so
Dr.
occludable
Sanjeev,
angles is
please
PSC.
conclude.
Yes, just. So how to document this? So this is prominent solid line posterior metoxin. This is broad iris process extending of the solid line, that is Axenfelden valley. S-separate configuration in case of plateau iris. And this is angle recession. So now I'm concluding. So gonioscopy is mandatory for diagnosis and management of glaucoma, and routine gonioscopy is essential to master the art and to differentiate normal from abnormal blood vessels. So my take-home message is start doing the gonioscopy. First start on the normal patients, on myopic patients, and then you will be able to understand the different structures. Thank you.
Thank you. I think the gonioscopy is, I think, the fundamental skill in ophthalmology and from glaucoma point of view. And if you look at the literature, the surveys where the glaucoma was missed, that was missed because the gonioscopy was not done, and particularly the angle closure disease. Now, angle closure disease, you have to remember, is more blinding than open angle glaucoma, and the blindness come very fast. So it can blind people very fast. So it's very important to recognize this. And if you look at the Chennai study and others, you'll find that the misdiagnosis rate for glaucoma is close to 80%. And even if you want to say open angle glaucoma, still you have to do gonioscopy. So it's not only for angle closure glaucoma, it's for all glaucoma patients. And it's becoming more and more important because nowadays the newer generation surgical procedures, they are angle-based procedures. So if you want to stay relevant in glaucoma surgery in future, I think you have to know gonioscopy, and if you're not doing it, start doing it now so that you're not left behind. So I think gonioscopy is becoming more important. It was always important from diagnosis point of view, but now it's becoming more important even from therapy point of view. So this talk is extremely important, extremely relevant, and we should all do it consciously for every patient. I think we'll check the number of speakers that are available so that we can adjust the time for discussion.
Dr. Harshika? Dr. Harshika? Dr. Swati? Dr. Arshi Singh? Dr. Shalini, you can come. And meanwhile, I'd like to ask Dr. Sanjeev, to the postgraduate, which lens, 1 mirror, 2 mirror, 3 mirror, 4 mirror, which lens you would advice to the young postgraduates who are starting?
In the beginning, I used to start with a single mirror or 2 mirror, and later on, because there is excellent illumination after that. So later on, when I started with a 4 mirror, I used to see only the reflexes and nothing else. But later on, I used with the 4 mirror. So my idea is start with a single mirror or 2 mirror, and then graduate to the 4 mirror.
One advantage a two-mirror gives is that obviously it creates a suction effect. So it's easy for a beginner to do. And obviously, instead of using a single mirror, I would recommend a postgraduate to buy a two-mirror, because at least you're able to do at least two areas or two 180 degrees and areas across simultaneously. So it makes your task easier and quicker. And it gives you a suction effect. So even if the patient is squeezing very hard, which is not possible with a 4 mirror, when you're using a 4 mirror lens, the entire thing has to come on with your hands. You'll have to hold it, whether you're using a handheld or with the one with a handle, whichever 4 mirror you're using. You will have to be very, very accurate in and you do not compress. Obviously, it cannot compress because it's a smaller size than the entire cornea. But with the 2 mirror, it creates a suction effect because of the viscoelastic being there, and also because of the convexity of the mirror, so of the lens. So as a result, obviously, for the beginners, starting with a 2 mirror, if you have to buy one lens, I would suggest you go in for a 2 mirror indirect gonioscopic lens, which is the Goldman type. So that would be my recommendation. What is sir's view on it?
I think that's true for in the beginning, because you want the lens to retain in position so that you can actually examine. But I think once you have gotten over that, initial hiccups, it's better to have a lens which is smaller, the smaller foot plate. So because with that lens you can do indentation gonioscopy. And also with 4 mirrors, you can actually see very quickly the four quadrants you can scan. With the larger mirrors like Goldman type, that you can't do indentation gonioscopy there. So there's a disadvantage with that. But I think initial learning, that's an excellent tool. But subsequently, I think you should move towards a smaller lens with 4 mirrors. Thank you.
That's on management of advanced glaucoma.
Good morning, dignitaries sitting on the dais of the dais and delegates. So I will be talking about advanced glaucoma management. So when we say advanced glaucoma, what is that? As per the International Classification of Disease, any evidence of glaucomatous optic disc and visual field, both in the upper and lower hemifields, or encroaching 5 degrees of the fixation, is advanced glaucoma. So any CD ratio of more than 0.8, mean deviation on visual fields of more than 12, advanced visual field defects, macular split, all if only temporal vision is left, they all are suggestive of advanced glaucoma. So we avoid the term end-stage disease just because it gives a pessimistic effect on the patient also. So let's see how big is the problem. When we see early manifest glaucoma trial, out of 32,900 subjects they screened, they found that 1.23% patients were previously undetected glaucoma, and out of those undetected cases, 33% patient had advanced visual field loss. Similarly, other trials also found that the advanced glaucoma has got pretty high number and it gets undiagnosed due to certain reasons. The goals of the therapy in advanced glaucoma, of course, is achieving target intraocular pressure. But besides that, it is also important to ensure that there is controlled diurnal variation in patients and there is no fluctuation in intraocular pressure. Therefore, there is no progression on visual field, along with good quality of life of the patient. That is also very, very important. And therefore, we need to give holistic approach to our patient. That is, we need to consider the biopsychosocial-spiritual profile of each patient besides aggressive IOP lowering. Like, we need to consider the systemic biology of the patient. What is the mechanism of glaucoma? What is the level of IOP? How is the rate of progression? And what is the life expectancy? There, we also need to consider the general health of the patient. If patient is having asthma or cardiovascular disease, we need to defer starting them on beta blockers. Similarly, other issues. Similarly, if psychological considerations, they also need to be considered, like if patient is on depression and the medication is increasing this factor, then we need not to start those medication. Socioeconomic factors we all understand is very, very important consideration because we need to give cost-effective therapy to our patients. It is a lifelong therapy. And then spiritual and cultural values. Suppose the patient who is fasting throughout the day, they will not use the medication if you give them 3 times daily. So tighter as per their own requirement. So first and foremost thing is establishing a target intraocular pressure. Now if we see the European guidelines, in advanced glaucoma it should be less than 12 millimeter of mercury. If you can keep it in single digit, it is well and more important. But besides this, it is also important to make sure that we consider other factors also. Like if life expectancy is longer, we need to have lower target intraocular pressure. If untreated IOP is low, we again need to have lower target intraocular pressure. We need to consider other additional risk factors for our patients, and then, as I said, rate of progression. Fast progressors should have lower target intraocular pressure. Now, when we say decision regarding the medical therapy in advanced glaucoma, medical management is definitely the primary intervention which we all do, but we need to give maximal medical therapy so that we get the target intraocular pressure, which is 4 drugs and 2 bottles nowadays. But besides this, we need not to miss certain important things like visual field. If patient is not able to perform on Humphrey's visual field, we have to go for Goldman visual field. Similarly, compliance and adherence is very, very important part. If patient is compliant, then only we can avoid the fluctuations in intraocular pressure. Check the bottles yourself. Instruct the whosoever person is instilling the eye drops. He may be needing, he may be using some of his relatives, friends to instill the eye drops. Just tell them how to do it properly so that the patient gets the adequate amount of medication. We can resort to preservative-free eye drops so that patient does have lesser side effect and therefore improves the compliance and adherence. And punctal occlusion is another very important thing which we need to instruct to the patient and to the relative also. The first and the most important thing which I felt is that we need to keep the hope alive in the patient's mind so that he has a good quality of life and feels optimistic while dealing in these cases of advanced glaucoma. Now coming to surgical therapy, we need to aim the risk and benefits of the surgery against the risk of progressive vision loss. So when to shift these patients? Whenever there is unacceptable risk of glaucomatous progression, we need to shift. If we are unable to achieve the target intraocular pressure, or there is poor diurnal control of intraocular pressure, or there is poor compliance and adherence, then we need to shift. Now, this was a Cochrane review which found 4 relevant studies comparing medical and surgical therapy, and they found that the medication was associated with more progressive visual field loss and less IOP lowering than surgery. Therefore, we can have a lower threshold for these patients regarding surgery. Now, when we say which surgery to choose, there are so many surgeries coming up, microincision glaucoma surgeries are coming up, but in all cases of open-angle glaucomas, NTGs and non-inflammatory glaucoma, trabeculectomy is still the gold standard surgery and tried and tested surgery with long-term results. In neovascular glaucomas, inflammatory glaucomas, or glaucomas where already trabs have failed, you can comfortably do tube shunt surgeries because now they have got good results, but then an expert is needed to do these surgeries, especially in advanced glaucoma. So if you are an expert, you can do it yourself, else better to refer these for tube shunt surgeries. For painful blind eyes, of course, cyclodestructive procedure are the choice. Now the patients of PACG with cataract, especially in advanced glaucoma, never do only cataract surgery. Always go for combined surgery because there is a misconception regarding it, and I would like to emphasize that in advanced glaucoma, combined surgery in PACG with cataract patients. Now, whenever you are going for a trabeculectomy surgery, which is the gold standard surgery, certain things are very, very important in your patients whenever you are planning, like preoperative mannitol you have to give. If you can do under topical or subtenon anesthesia, it is good. If you are giving a peribulbar block, give small amount of anesthesia and small dosage. Don't inject bigger amount, large amount of anesthesia altogether in peribulbar area. Another thing is never apply pinky ball in already compromised optic nerve head. You can give intermittent digital massage so that there is not sudden onset increase in pressures which might lead to a wipe out phenomena in your patient. Another important thing is you have to avoid sudden lowering of intraocular pressure. So make a side port and avoid any hypotony during the procedure so that you don't land up into shallow anterior chamber. You can always use cause modification, which is the Moorfield safe surgery system, to give results to your patients. So, do I have the time?
I think your time is over, but if you want to make a specific point, it's okay
Okay.
because we don't have other speakers. So, yeah, you can give you another 2 minutes. Yeah.
Okay. So the main concern is that unexplained irreversible loss of central vision we need to avoid. And because after trabeculectomy surgery, vision definitely drops down by few lines. So explain the patient beforehand that initially there will be drop in the vision and later on you can regain your vision. Another important modality which I found is useful in these patients whenever you cannot resort to surgery. Suppose there is a patient who is old and frail and you cannot take him for immediate surgery like if he is needing, then you can go for some laser procedure to bypass that small phase and later on go for surgery. So adding laser therapy, it can be a micropulse laser or a laser trabeculoplasty along with anti-glaucoma medication to bypass that small phase of problem. So surgery is contraindicated. If patient is not giving consent for the same, you can go for this laser, which definitely controls the intraocular pressure for short term, although later on, the pressure tends to rise in many of the patients. So micropulse technology is another thing where you get small pulses of laser with intermittent areas where you don't get any lasers. Therefore, the reduction in vision which is seen with other cyclodestructive procedure is not seen in this kind of laser. So, in micropulse laser, you can take up the patient under topical anesthesia, and then you can simply apply the probe at the limbus, and it is kept 2 millimeter away from the limbus, and then you can sweep it 180 degrees superior and inferior, leaving the nasal and the temporal areas, and therefore the patient gets reduced intraocular pressure without much increase in inflammation. Now in cyclocryotherapy, there is lots of inflammation which is there seen in immediate post-operative period, which is not seen with this kind of micropulse laser. So we have our experience with certain number of patients and in variety of glaucomas, but in primary open-angle glaucoma, we found a sustained decrease in intraocular pressure, but other secondary glaucomas, it was a mean reduction was good, but later on the pressures, they started rising up. So the take-home message is that we need to do aggressive IOP lowering in all patients of advanced glaucoma. It is not just IOP lowering, it is the holistic approach we need to give to our patient. We need to have lower threshold for surgical management, and we can combine sometimes laser with anti-glaucoma medication if surgery cannot be resorted to. Thank you so much for your kind attention.
Okay, thank you, Dr. Shalini. I think you have covered a lot of ground as far as management of advanced glaucoma is concerned, and this is again a topic which can be discussed endlessly. But I think realistically speaking, I mean, when you see a patient with advanced disease, what are the few key things that you look for, and how do you initiate a treatment? Because that's what everyone faces when you see. Now I have a patient of advanced glaucoma. Now, how do I approach that patient actually in more practical terms?
So, first of all, we need to make sure that the diagnosis is of advanced glaucoma. There might be other mimickers which look like glaucoma, but actually they are not. So, first and foremost is confirming your diagnosis. So, you need to do applanation tonometry, which is very, very important. Then as just now we had a wonderful talk on gonioscopy. So for gonioscopy, we need to make sure which type of glaucoma we are dealing with. And more importantly, suppose you have diagnosed primary open angle glaucoma for the first time, that doesn't mean that you need not to repeat gonioscopy regularly. So yearly gonioscopy is advisable in all the patients because the lens thickness increases, and that can again lead to narrowing of anterior chamber. Third important thing is visual field examination. If patient is having good visual acuity, then of course you can go for automated perimetry, whether Humphreys or Octopus, depends on your own choice. But if the vision is less than 6 by 60, the patient is unable to perform in Humphreys visual field, then you must go for Goldman visual field for documenting your finding. Now, OCT doesn't have much role in advanced glaucoma, although ganglion cell analysis you can do, but we would not recommend OCT for advanced glaucoma. Now, once you have made sure that diagnosis is there, then as I said, target intraocular pressure, you need to be sure about target intraocular pressure. And target intraocular pressure, make sure that it is in single digit. It is 10 or less. That is best in the cases of advanced glaucoma. Now, after that, ensuring that target intraocular pressure you have decided, then you move on to medication. Now, medical therapy, of course, if patient is of advanced glaucoma, we can go for a combination therapy. If prostaglandins are not contraindicated, as a primary therapy, we go for prostaglandin with beta blockers. Now, if there is any contraindication to these, then of course we have to check for brimonidine and carbonic anhydrase inhibitors. Now, once you have started the patient on medical therapy, it can be a combination drug, and then you need to make sure that how much reduction is there in intraocular pressure. You must achieve at least 30% reduction or 30 to 35% reduction out of these. And if you are not getting pressures controlled on target intraocular pressure, then you need to add the medication. Now, adding medication and then again asserting that target intraocular pressure has been achieved. Now, that is not the only thing which we should do. Besides lowering the target intraocular pressure, we should also check that the diurnal control is very, very important. Now, suppose you are in a private practice where you cannot admit your patient for checking the intraocular pressure every 3 hourly. So you can do an office diurnal control. That means you can call the patient at different times of time. Suppose once you called him in the morning, then in afternoon, next day you called him in evening, and then at night. So that way you can get an idea that what is the intraocular pressure at various times of day and is it controlled or not. If there is a fluctuation, that means you need to adjust your anti-glaucoma medication according to that. Now, once you have achieved by medical therapy, you need to follow up your patients by visual fields. And if it is well controlled, well and good. If it is not, I would suggest that you go for surgery, because surgery, besides controlling intraocular pressure, also controls the diurnal fluctuation in intraocular pressure. So surgical management should be resorted to these patients with explaining that there will be immediate drop in the visual acuity, which will be regained to the previous levels after everything comes to the normal.
Any questions we have from the audience? Just add to what Dr. Shalini has just said. Besides obviously looking at the IOP fluctuations by diurnals even after therapies have been started, it's also important to take care of the other vascular risk factors, which obviously are responsible for the decreasing the ocular blood flow to the optic nerve. So please remember, whenever you're doing your diurnals, even after your medications or before you have actually started medications for any type of glaucoma, please check their blood pressures also along. So as you get the ocular perfusion pressure, which is actually the most important thing for glaucoma management, besides lowering of the IOP. So you should always take care of those vascular risk factors, or the dysregulation of the vascular blood flow which is happening to the optic nerve. So please teach, as she said, a holistic approach is very, very important. It's not just IOP drop. You have to take a holistic view. Any other questions which anybody wants to ask?
In any patient with macular split, you suggest anything intraoperatively or surgical
She
measures,
already
special
gave
measures
those
you would
things.
like to take?
It is very, very important that sudden reduction of intraocular pressure has to be avoided. And as I said, avoid super pinky balls. And whenever you are entering the anterior chamber, you have made your flap, you are entering the anterior chamber, before that make a side port. Inject viscoelastic so that you don't have sudden flattening of anterior chamber. If hypotony has been avoided and sudden flattening of anterior chamber has been avoided, you will never get any problem in all these patients with macular split. So that is the main important thing. In fact, whenever you are doing the closure, it should be a tight closure. You can put a releasable. You can later on release that. But if in immediate post-operative period you have a flat AC, then it's a problem. So we have to avoid this important factor, and then you will not have any problem.
In fact, in some of the cases, it is even recommended that if it's a pseudophakic patient you're operating on, you can even use your AC maintenance. You do not want the sudden loading of the IOP to happen. So you can even use it initially, make it initial entry and put an AC maintainer if required in those cases, instead of injecting visco if you want. Gradual decompression is very important to prevent this wipeouts which can happen.
So, Professor Shalini and Professor Vinita, madam, with us, if anybody has any other doubt. I just wanted to add this, like with glaucoma patient, it is.
Any lifestyle medicine is needed?
Sorry, I couldn't get your question.
Addition to the medication or surgery, any lifestyle medication.
That's what I said, now all the vascular risk factors. Like, in fact, Shalini has presented some cases in previous talks. There was a person who was practicing a lot of yoga. Yeah, and blowing, trumpet blowing and all those things.
Right.
So you have to take care of the profession also. That's why she said there's a holistic approach. You have to know the profession also. Maybe he's doing some activities which are actually increasing his IOP. You're adding on drugs, you're doing so many things, but you're not taking care of his general lifestyle. So all those lifestyle modifications
So
have to be there.
any of the thing which is leading to Valsalva maneuver, it might be a trumpet blowing, it might be heavy weight lifting, it might be Shirshasanas. So anything which is causing Valsalva has to be avoided.
Yeah, I just wanted to add like this, like other eye diseases, glaucoma is one disease where it's almost like कि आपको patient को गोद लेना है. It's not a one-time process. If you do trab, see, we do one phaco, we forget about the patient until he comes for the next eye, right? That is not so with glaucoma. With every step, we have to have lot of follow-ups, more so in surgicals. We have to see how the sutures are, how the IOPs are, whether we have to give massage, when we have to release the suture or do the LSL. It's a very, once you have taken a glaucoma patient, as if you have adopted that patient, he will be with you lifelong. Like a skin disease, no? They always come. And it's a very good paying patient also to you. So, and the importance is, please ask the patient to maintain all the records. In institutes, it's very good, like they have all the MRD number and all. In smaller places, the problem comes, patient comes with one visit and you have seen everything, you have advised everything. Patient comes, next visit, everything is gone. वो तो सर भुला गया. अब you do not know what was the IOP earlier, what is now, कौन सा medication ले रहे हैं. Please emphasize कि आप अपना एक फाइल बना लीजिए और जैसे आपने अपने 10वीं क्लास से लेकर अभी तक के सारे सर्टिफिकेट्स और लैंड रिकॉर्ड्स रखे हैं वैसे ही आपको ये रिकॉर्ड्स रखने हैं. दैट इज़ वेरी वेरी इंपॉर्टेंट इन फॉलो अप एंड दैट इज़ हाउ यू विल सी व्हाट द टारगेट प्रेशर शुड बी when you should switch for the surgeries and all. Anything?
There was
Yeah.
a question from the back.
Yeah, please.
Ma'am, according to your study that you showed about micropulse laser, you said that the secondary glaucomas did not work very well. Then you subjected the patients to trabeculectomy later on, and what was the result as compared to a non-micropulse laser trabeculectomy? Was there any difference in the result in between the two groups?
Now, with this, we have slightly modified the procedure. We leave one quadrant for future trabeculectomy, especially in secondary glaucomas. Now, but the best part of this micropulse laser is it doesn't cause any scarring of subconjunctival tissue. So even when we lifted the conjunctiva, it was not scarred. Else, you do any other cyclodestructive procedure, you find that conjunctiva is scarred over there, and doing trabeculectomy is not very successful. But as I said, these secondary glaucomas, especially neovascular glaucomas, you can do micropulse, but I do primary tube surgeries in these patients because we know that the scarring is so much that ultimately it leads to failure of trabeculectomy. So in these cases in which failure of trabeculectomy is very, very high, I go for a tube surgery in these patients. So after the patients which I showed, in few I did trabeculectomy, but in which likely especially post VR surgery and NVGs, I do primary tube in all these patients and get very good results. What? All. Because it decreases the side effects of any of the medication. So it is always advisable. In fact, ideally it should be done for all the drugs, all ophthalmic medication.
Why for AGMs? All ophthalmic medication.
for all
Because
eye
everything is
drops.
specifically absorbed from your nasal mucosa, even for atropine, everything. So you have to have punctal occlusion.
So
If you
punctal
can
o-
advise that for 3 minutes at least.
No, for
medication,
every
every
ophthalmic
medication.
preparation. So for glaucoma, it has been emphasized again and again to improve the efficacy and to reduce the side effect because these are long-term medication. But otherwise, it is indicated in every ophthalmic preparations.
Madam, if we plan for trabeculectomy, glaucoma surgery, and the pressure is still not controlled even after installation of mannitol, then what is the next step?
Look, if it is not controlled and you want to proceed for trabeculectomy surgery, you have to. But then, as we discussed, slow decompression is key to the successful trabeculectomy surgery. So if you go slowly, in fact, I remember Dr. Ramaji Sihota, she used to simply sit for 2-3 minutes, wait for everything to release, and then only she used to do surgery. So better to wait and let the aqueous egress be very, very slow, very, very gradual, and then you can proceed for the surgery.
What is the level of IOP, like 30 mmHg or 40 mmHg, can we try for, go for trabeculectomy?
Yeah, if it is less than 30 millimeters of mercury, you can go for trabeculectomy surgery.
More than 30, if IOP
But
more than...
generally by mannitol, it comes down. So if you give mannitol, if you give Diamox, if glycerol is not contraindicated, you can glycerol. And all medication, it generally comes down. Suppose if it has not come down, then you can do certain other procedures like lasers and all, and then you can reduce the intraocular pressure, and later on you can go for surgery. But Dr. Vinita, what is your opinion?
Micropulse, like as she said,
Yeah.
micropulse laser can be done in these cases. As you're saying, the pressure is still, despite all the medications, even after giving mannitol, if it is not, it's a resistant type of glaucoma. Do micropulse laser, wait for 2 weeks, let the effect of the whatever the ciliary body abrasion you have done with the micropulse laser, let it come back. Because obviously, once the ciliary body will start reducing the aqueous production, obviously some IOP reduction would happen. So that is, and then you can proceed with your trap.
Regarding mannitol, you have to go it very fast. Fast
Yeah,
infusion
and
is to
another
be
thing
given. Then
first-
only the effect comes. If you give it very slowly, the effect will not come.
Please make sure it is given as a bolus dose, because
In-
till you give it as a bolus dose, the IOP will not drop, because it is working by causing dehydration of your vitreous cavity actually.
Moreover, you can give it for few days. Suppose by monitoring various other parameters, you need to monitor blood pressure, etc. with mannitol. You give it for 2-3 consecutive days, twice daily, and then gradually you will see that pressure starts reducing. Suppose in cases of very high morphic glaucomas, acute angle closure glaucoma, I guess you are talking, where pressure doesn't come down immediately after mannitol, then you can admit the patient, give mannitol twice daily with monitoring all other vitals, and then gradually you will see the pressure start slowing. Don't enter in very high pressure eye, otherwise it will lead to expulsive hemorrhage.
About the macular split, I think we have overemphasized about snuff out phenomenon. It is not. Shankar Netralaya has done one study in which they have operated on around 70 people with macular split. They have not seen any single snuff out phenomenon. It is mostly because of sudden release of macular edema and all, which settles down. So don't get very much worried about split. See, if there is a split, still we have to say whatever is left, and we have to intervene. So don't let the patient go only because of that.
Operating the patient.
That is one thing. Second thing, the slow decompression. No, it's a very, very important step. Very well. All those expulsive and all those dreaded complication is only because of that sudden decompression. So when you go with the side port, you stay there. You stay there, and step by step you just withdraw it slowly. In one of those videos of, if you see Ike Ahmed, he has taken around 2 minutes to withdraw that. So that is very important step. If one step you have to be very careful is that slow decompression. You
Like
can.
you do for CRAO, what is your purpose? It's doing slow paracentesis for CRAO also. The purpose is the same. So obviously you can just, you can just press the posterior lip gradually with your MVR or whatever is the thing which you are used for side port entry. Just press the posterior gradually, so that gradually you're reducing the pressure at the time when you're entering with the paracentesis.
So I would like to thank, because the next session is already there, I would like to thank all the, you can take madam outside, and madam is there on the lunch and all. You can talk personally to madam and all, because other speakers already. I would thank all the speakers for their wonderful presentation. Madam, thank you very much. Jadhav sir has already lot.
Thank you so much.
And
Thank you, everyone.
Shalini madam, thank you very much for all
Thank
this.
you. Thank you so
Excellent.
much.